In this video, I would like to show you phacoemulsification of a hard cataract in topical anesthesia. Nowadays, people are doing it more frequently under topical anesthesia. Patient cooperation is extremely important. Now, first, after putting topical anesthetic drops, make a main incision at 12 o'clock with 2.75 phaco knife, and now put air, and under the air stain the anterior capsule with the trypan blue dye. Remove the air. Now put viscoelastic. Remove the air bubble while putting the viscoelastic. Now make side ports with 15-degree knife. I made 2 ports, side ports with 15-degree phaco knife. Now this patient was very uncooperative. He was moving the eye around, and I had to constantly request him that please look into the light. You promised me that you will cooperate. Now you can see that I have held the globe with the corneal forceps. That's also one of the way to keep the globe steady while doing the most important step, Capsulorhexis, when the patient is moving his or her eye when you are doing it under topical anesthesia. Now, as you can see, I started the rhexis and stopped because the AC became shallow. I came out again, put viscoelastic, and now continued the rhexis, because rhexis is one of the most important step, and if the rhexis goes radial, then the phacoemulsification becomes extremely challenging. You can also see that in order to keep the eye in primary position, I have to make an extra effort. And now again today in this video, in this phaco, I have skipped the step of hydrodissection and hydrodelineation, because in a white cataract as well as in a mature cataract, I don't perform it. There is no need. Now I have removed the epicortex, and now you can see I am chopping the nucleus. I put the phaco probe in the center, hold it with vacuum, elevate it, and then with the second instrument break small piece. So in this way I use less phaco power, and most of the chopping I do it mechanically with the second instrument. So though this technique is anterior, the next day the cornea is shining, and when you break it into many smaller pieces, it is very easy to emulsify. Now I came out half of the nucleus inferiorly I have emulsified, but superior half is left, so that's why I came out. I put the gel, and now with the help of a dialer I am pushing the superior piece inferiorly so that it should come into working place. Now this tilt, elevate and chop technique has got many benefits. There is a 0% chance of posterior capsular rupture, and if you put frequent viscoelastic and do it under less phaco power, then it is a cornea friendly technique as well. Now posterior cortical sheets are left. and they can easily be removed with the Simcoe cannula. Make sure that your view is very clear and you see an anterior chamber is not collapsing while removing the cortical sheets. You can remove the cortical sheets from the main port if you have a good stable hand, and you can use one of the side ports as well. So now all the cortical sheets are removed. Again, gel is put to create a space to implant foldable IOL. Aim the injector towards the center of the bag so that the leading haptic should enter inferiorly at 6 o'clock into the bag, and superior haptic you can put it with the help of a dialer. So now I have placed it in the bag. Now remove all the viscoelastic from the anterior chamber from the bag. Now that is very important, because if you don't remove all the viscoelastic, next day there is reaction, there is inflammation, and cornea is also hazy. So try to remove all the viscoelastic. Also you can do capsular polishing if there are some fibers on the posterior capsule, because now you have got support of the IOL. When there is IOL in the bag, you can easily do capsular polishing. And now hydration of the ports at the end. So that was a case of phacoemulsification in hard cataract with my tilt, elevate and chop technique under topical anesthesia. Thank you very much.